I'm going to touch upon the basic aspects of how to look at the PDA and how to assess and determine if the PDA is hemodynamically significant or not. So, touching upon the basics, we know that ductus arteriosus is an arterial channel connecting the main pulmonary artery to the descending aorta. So, anatomically, if you look at it, comes as from the right ventricle, there is a main pulmonary artery which divides into two, right and left pulmonary artery, and then there is this channel which connects to the descending aorta, generally generally to the next to the left subclavian artery. But if you see three-dimensional orientation and lateral view, then what happens is that this blue structure is basically the main pulmonary artery which divides into the right. So this one is the left pulmonary artery and the right is on the other side, which is we are not able to see. This red structure is a arch of aorta and this becomes the descending aorta. And the purple color structure over here is the ductus arteriosus. So precisely when you are going to look at PDA on a lateral view on the 2D echo, what you're going to see is it's a continuation of main pulmonary artery. The most cephalic or most cephalic or most on the right side, the continuation of the main pulmonary artery is a ductus arteriosus. Now, ductus arteriosus has a large number of circularly arranged smooth muscles in this medial layer. And when the pH of the blood which is passing through the ductus arteriosus reaches about 50 millimeters of mercury, the ductal wall constricts. So normally the blood which is flowing through the ductus arteriosus has got PaO2 of around 35. And that is the most or highly oxygenated blood in the fetus and which is coming from the which is but less than 35. So the blood which is in the aorta has got 35 and the blood which is going through the ductus arteriosus is about 17 to 20 millimeters of mercury. And this particular blood is coming from the right ventricle into the main pulmonary artery and it is going into the descending aorta. Now when this PaO2 of this blood reaches about 50 millimeters, the ductal wall constricts. Now there are two main important closure. One is functional closure, where the smooth muscle constrict by 1 to 3 days after the baby is born, and that happens because of increased PaO2 and decrease in prostaglandin levels because of that. And then there is second, which is anatomical closure, which is by endothelial remodeling with fibrosis, and which happens by around 3 weeks. Now, during this fibrosis, during this extreme constriction of the duct, the vasa vasorum, which are within the vessel wall of the ductus arteriosus, they undergo ischemic change, and because of that there is a fibrosis and then there is a permanent anatomic closure of the duct. Now when we know about this, we have to also remember that when a duct is initially closed in the first 3 days, 4 days, it may be just the anatomical, it just may be the functional closure, and when the baby has an episode of sepsis, fluid or any other sepsis or mainly fluid overload, the duct may reopen. So this is very important to know that sometimes the duct is reported closed on the 5th day, but then later on in the 2nd week or 3rd week, the duct again reopens and clinical symptoms. So sometimes you need to monitor the duct little longer and be aware that duct can reopen again by around 3rd week. Now again, this is an important question: when to call a PDA abnormal? Because we know that PDA is a normal structure. It has an important role in the fetal life, but then it is considered abnormal if it remains open beyond a certain time frame. So we do not know what is the time frame. Suppose you do echo on a baby at 6 hours or 8 hours, so 10 hours, you will often see the PDA open. It's the time frame that you call that the PDA is abnormal. But traditionally, 3 to 4 days is the time frame when you consider that the PDA will be closed. Or a PDA which is there but which is causing hemodynamic consequences in the baby, then it is considered abnormal. Or when symptoms which are ascribed to PDA are present in the baby. So either it is hemodynamically significant or if there are clinically symptomatic PDA. And what are the symptoms when the baby has a PDA? Either apnea, respiratory distress, etc. So again, as I said, the PDA may reopen by about 3 or 4 weeks. So what are the symptoms? What are the consequences of presence of a PDA? PDA causes pulmonary flooding. So there is increased blood flow in the pulmonary circulation, which may lead to hemorrhagic pulmonary edema or sometimes frank pulmonary hemorrhage. There is increased chances of chronic lung disease in a baby who has got a PDA or open PDA for a long time. And then there is abnormal vascularization which takes place, and later on which will present to you with a pulmonary hypertension by around fourth decade. So again, these are important things that we need to remember when we are talking about PDA. Also, the PDA may lead to systemic steal, where there is a steal of blood from the cerebral circulation leading to perfusion reperfusion injury. There may be splanchnic circulation leading to necrotizing enterocolitis, and sometimes it may lead to pre-renal azotemia or renal failure because of the poor perfusion. Sometimes it may lead to systemic hypertension. Up until now, we knew that PDA causes only diastolic hypertension, but now we know that it can lead to systolic as well as mean BP also can go down. And PDA, which is a significant hemodynamically significant PDA, can present to you with a high output cardiac failure. Now, these are the problems that you will face with presence of a PDA. So how to assess a PDA? So most important thing is assessment of the clinical assessment of the baby. So look, make sure that the pulses are all palpable. Make sure that you are not dealing with a drug dependent lesion. Palpate pulsation in the left hand as well as the lower limb, and look for the dysmorphism, and look for the signs of congestive cardiac failure. Besides clinical examination, for assessment of the duct, most important is 2D echo. Now, when you do 2D echo, look for the patency of the duct, size of the duct, and magnitude and direction of the shunt. Number two, assess for pulmonary overcirculation, and assess for signs of systemic hypoperfusion on echo or steal phenomena that is caused by PDA. So these are the three important things. Characteristics of the PDA by patency, size, and magnitude of shunt. Number two, look for pulmonary overcirculation. And number three, look for systemic hypoperfusion. And then look overall echo to see if there are any associated cardiac anomalies. So again, weak femoral pulses, pulse difference may lead to arch, may indicate arch lesions. So it is very important that you have to clinically make sure that there is no difference in the pulsations in the upper limb and the lower limb, and you are not dealing with the arch anomaly. Also make sure that the routine pulse oximetry is done. Now, during treatment of PDA, presence of duct-like tissue is there at the aortic isthmus, and therefore sometimes it may constrict. So it is very important to remember that when the duct is present, we treat the duct with a prostaglandin synthesis inhibitor medication, but the ductal musculature sometimes may extend into the aortic isthmus, and that may lead to
sorry, there is someone who's waiting to join. Rohit, please allow him.
Yeah.
Yeah, please go ahead.
Yeah. Sorry, there is some, I think, is the noise disturbance? Some construction is going on the next somewhere. So basically, even if the PDA is closed, so even if there is no coarctation of the aorta initially reported, sometimes when the PDA closes, because the duct-like tissue is sometimes present in the aortic isthmus, with the closing of PDA, that tissue also might constrict, and the patient may present to you with a symptom suggestive of coarctation of aorta. So always be remember, I have seen a lot of neonatal or pediatric cardiologists avoiding mentioning no coarctation of aorta when the PDA is present. The reason is that sometimes when the PDA closes, there may appearance of coarctation of aorta because of the duct-like tissue which is there at the aortic isthmus. So we should be aware of this, and when on treatment, we should also keep on palpating pulses. Now, complete cardiac echo, basically complete examination of the heart from four different views. Look for any underlying structural heart disease, and it is important to look at the chamber size, unobstructed flow across all the walls. Now, where do you look for duct? You look for the duct at high parasternal view. Now, some people recommend putting the probe on the left side of the manubrium, and sometimes it may be visibly better on the right side of the manubrium on the high parasternal area. Most commonly, the PDA view is left high parasternal view, just next to the manubrium sternum. Now, here you have to assess the characteristics of the duct. So let's go. So you put the probe just on the left of the, here it is slightly on the right, but as I said, you can do it from the right or left. Traditional teaching is that you put the probe on the little left of the manubrium sternum. Make sure that the orientation marker is facing 12 o'clock. Tilt the probe slightly towards left, so that the beam slightly towards right, so that the beam crosses in the left hemithorax and it will be aligned with the pulmonary artery. And then what you see, as I showed in the previous figure, basically the the you trace the main pulmonary artery and you trace it forward, and the most cephalic or most cephalad continuation of main pulmonary artery is the ductus arteriosus, and try and locate this ductus arteriosus as it opens into the descending aorta. So in that particular image, in the left high parasternal ductal view, what you will see is this Mercedes-Benz is a aorta, but you don't see Mercedes here. In that view, you will see mainly the main pulmonary artery. You will see right pulmonary, left pulmonary, and most cephalic continuation of main pulmonary artery is a PDA, which opens into the aorta. And realistically, it is seen like this. Now, if you are able to see 1, 2, 3 legs like this the most cephalad one is the PDA. Now some people have called this as a tripod sign. You're able to see 3 legs of a stool, and these 3 legs is, one is right pulmonary artery, this is a left pulmonary artery, and then this one is a PDA, which opens into the descending aorta, which is obliquely cut, so therefore not completely seen. Sometimes you may not be able to see the right pulmonary artery if the view is like this. So basically, as I said, PDA is seen as a cephalic continuation of main pulmonary artery. It joins the descending aorta. The size of PDA is a not good guide to decide whether it is a PDA or any other vessel, because sometimes the PDA can be as large as aorta, and therefore don't go just by size of the duct or size of the vessel. That smaller the vessel, it is PDA. It is not true. Sometimes PDA can be as big as aorta, and large PDA will be seen as an open channel. So once you now located PDA with the help of 2D echo, now when you put a color Doppler, you will be able to see patency or blood flow across the PDA. So it appears as a colored jet from aorta into the main pulmonary artery, because the aortic pressure is higher than the main pulmonary artery most of the times, and therefore you will see a red colored jet of blood coming from aorta into the main pulmonary artery. So this is again images which are taken by me. As you can see, this is the right pulmonary artery, not properly seen because obliquely cut. The left pulmonary artery is aligned with your axis of probe, so you are getting good view of left pulmonary artery, and just ahead of it there is a this duct. Now visibly it looks like it's a constricted. You can see the channel over here, but when you put a color, you will see that there is a still some flow which is coming from aorta into the main pulmonary artery. Now please focus here. Can you see this bright spot? This bright dot here is a divider. Okay, so this bright spot is very easily seen. When you do a 2D echo, please focus and try and find out this bright spot. Another very important point I want to mention over here is that when you are measuring the size of the PDA, what you are supposed to do, you are supposed to put a color here, like the way it is put here, color Doppler. Now through the color Doppler, you have to adjust the gain so that it is not too bright and not too light. So that there is no, you have to adjust the scale. This scale over here is 47. Adjust the scale and adjust the color gain in a way that you are able to see a uniform jet. Now, when you do that, you have to make sure that you measure the width of PDA within the lumen of PDA. So it is the smallest transductal diameter. So when you measure it, so you have to remember that you cannot measure it here. Okay, because this is within the lumen of the main pulmonary artery. Your PDA starts here, this point, and from there the PDA is here. So this particular part is PDA. Okay, and this particular is a jet. So some people make a mistake of measuring PDA size here, which is wrong, because this is a jet. It is not a PDA. It is jet coming from PDA. I agree, but But then this is not PDA because anatomically PDA starts here from this bright spot downwards. Okay, so this is a common mistake people do, that they will measure PDA size here and then they'll report the PDA is around 2 millimeter, whatever. So that is not true. So from this point of PDA till it opens into the aorta, whichever is the smallest transductal diameter is the size of the PDA. So size of the PDA depends upon the ductal constriction. Ductal constriction typically begins in the pulmonary end or in the middle of the duct. If there is no PDA, there is no flow across duct. Small PDA, there is good constriction. In a moderate size PDA, there is minimal constriction. And in a large size, there is no ductal constriction. Now, why I have said this, when we are reporting PDA, we look for constriction. And we report it as no PDA, small PDA, moderate or large PDA. So to just give an example here there is no PDA. If you look at the main pulmonary artery on 2D image also, this is the right pulmonary artery, this is the left pulmonary artery, and there is nothing seen here. And when you put your color, there is all blue colored jet which is going into the main pulmonary artery. So there is no PDA here. This is some turbulence red color, but there is no PDA because PDA is a most cephalad continuation here. Now this is a small PDA. The PDA is constricted well and the size is less than 1.5 millimeter. It's a small PDA. Now, if the PDA size is more than 1.5 millimeter or there is a slight constriction, then there is a moderate size PDA. And if the PDA is seen like this, where there is absolutely no constriction, and then there is a channel is as big as left pulmonary artery or right pulmonary artery, and there is absolutely no constriction in the PDA channel, then it is a large PDA. And this large PDA will be invariably more than 1.5 millimeters, will be more than 2.5 millimeters. But now calling it based on the size of the PDA, there is some confusion. A lot of people will call a PDA more than 1.5 millimeter as a large PDA, and some people will call PDA more than 2.5 as a large PDA. But again, as I said to you, measurement of PDA sometimes can be erroneous, and it also depends not only on the size of the PDA, but also depends upon the amount of constriction within the lumen of the PDA. So when somebody calls it as a large PDA, it is an unconstricted PDA and generally more than 2.5 millimeters. Again, this PDA, as you can see, there is no constriction, size is 3 millimeters. So this is the large PDA. 2.5 to 3, some people call as a large PDA. Now we have established presence of PDA. Then we have seen the direction of the blood flow within the PDA, and we have tried to measure the size of the PDA. So now we have seen now we are going to see what is the direction of the shunting within the PDA. Now, obviously, that particular blood was coming as a red colored jet, but sometimes when the pulmonary pressures are very high, the blood is going to flow from the main pulmonary artery into the descending aorta, and in that case, the blood is going to be seen as blue in color. Now the blood which is flowing into the right pulmonary artery is also blue, left pulmonary also is blue, and when the PDA flow is also blue, it becomes very confusing how to find out whether that is PDA or we are misjudging left pulmonary artery as a ductus arteriosus. But again, you have to carefully see, look for tripod sign, look for all the three vessels in case of PDA, and then put the Doppler gate at entry point of ductus arteriosus into the main pulmonary artery. So as you can see, you put a pulse wave Doppler in this direction, put the Doppler gate here at the entry point and put the Doppler on. So what happens is that here you will see the flows like this. Now this is a left to right shunt purely. This is a the lower part is a right to left shunt, the upper part is left to right shunt, and on the extreme right, here you will say predominantly there is right to left shunt and a small amount of left to right shunt. So here the pulmonary pressures are very high. So again, a ductal flow pattern we have to measure, and that will help us in establishing. So abnormal PDA shunt is considered when right to left shunting is more than 30% of cardiac cycle. And that happens when the pulmonary pressures are very high. So when you're putting the pulse wave Doppler in the ductus arteriosus, if you are seeing more than 30% of the cardiac cycle is right to left, then there is a pulmonary hypertension in the baby. So it is very important to remember that in the first 72 hours of life, normally the PDA can remain open. Now, in the first 3 days, if we say PDA is open, then when to treat it? Which one to treat it? And when to call it as abnormal? Now, this is a big question mark. So, what happens is that we obtain a high left parasternal view, ductal view, assess the duct patency and flow characteristics in the middle of the PDA with pulse wave Doppler, and categorize the ductal pattern into one of the 4 patterns: bidirectional, growing, pulsatile, and closing, and measure the and calculate the pulsatility ratio. So I'll just show you. So in the first 72 hours, the ductal assessment depends upon the flow pattern in the duct. So these are the 5 patterns actually, but this is common pattern. So one is pure right to left shunt, where the pulmonary pressures are high and blood is only flowing from main pulmonary artery into the descending aorta. So this is abnormal. This normally you will never see. If you are seeing this pattern, it means that the child has got underlying cyanotic heart disease unless proven otherwise. Now the second pattern is bidirectional pattern. Now bidirectional pattern is also not normal, and we call it as bidirectional when right to left shunt pattern or right to left component is about 30% or more of the cardiac cycle. So if you see from point this to sorry, I think so. So from point this to point this is a cardiac cycle, and this is a right to left component, and the first one is left to right component. So if the right to left component is more than 30%, it means that the pulmonary pressures are high, and this particular shunt, one would call it as a bidirectional shunt. Now normally bidirectional shunt is not seen, and it is seen only in pathological conditions such as pulmonary hypertension, and this can happen because of meconium or lung disease. And this is bidirectional shunt. Again, this bidirectional shunt you do not treat. The third category is a normal pattern which is called as growing pattern. So in a baby, in the first couple of days, you will see this pattern very often, where there is a predominantly left to right shunt and a very small component of right to left shunt, or less than 30% of cardiac cycle. Now this particular pattern is very normal in a baby in the first few days. And the next pattern is pulsatile pattern. Now what happens is that one large positive wave and second small positive wave. So this pulsatile pattern is this is called pulsatile pattern, and the last one is a closing pattern where there is a continuous flow, and now how to differentiate between D and E, that is pulsatile and closing, I'll show. So basically what you do is that you take the velocity maximum and velocity minimum of that particular waveform. Now if this ratio is more than 2, it is considered as a pulsatile flow pattern, and if the ratio is less than 2, it is a continuous pattern. So which PDAs you treat? You treat PDA which is in C pattern or D pattern. If it is a growing pattern or a pulsatile pattern, along with size of the PDA and amount of constriction. So how do you decide whether to treat PDA in the first 72 hours? It depends upon the size of the PDA, amount of constriction, and what is the flow pattern across the PDA. If it is a growing pattern, pulsatile pattern, you would treat it. If it is a closing pattern, you may not treat it. If there is any doubt, you wait for another 6 hours, see which way the pattern is moving, and based on that you can take a decision whether to treat or not treat. I hope this is clear, or maybe you can ask questions later. We'll discuss. Now this particular study, less than 32-week babies, echo was done on the second day of life. Now what they showed is that factors which are associated with ductal patency at 1 month were a larger ductal size, more than 2.5 millimeters, or a lower end diastolic flow velocity. In effect, what it means is that it is a pulsatile pattern, and peak systolic to end diastolic flow velocity ratio of 2.2 versus 1.2. So essentially, it is what it means. This particular study means is that if the duct is larger, it is unlikely to close. If it is pulsatile pattern, unlikely to close, and both basically mean that it is a pulsatile pattern which is unlikely to close. So therefore, we kind of recommend treating babies with a larger duct and with a pulsatile or a growing pattern to treat the PDA. Now, so this completes the assessment part of the duct, but then we have to also assess pulmonary overcirculation and systemic steal. That will complete the assessment of the PDA. So when we look at pulmonary overcirculation, we do Doppler of left pulmonary artery. Now put the pulse wave Doppler here and press the button and look for the diastolic velocity in the main pulmonary in the left pulmonary artery. Now normally in the left pulmonary artery there is no diastolic blood flow, but if you are seeing a little blood flow, it is a mild PDA. 30 to 50 centimeter per second is a moderate PDA, and if you are seeing more than 50 centimeter per second, it is a large PDA. So again, this is a normal flow pattern in left pulmonary artery. There is no blood flow during diastole. So assessment of main pulmonary artery, again parasternal short axis view. So how do you do that? You put the this is the pulse. This is the uh, cardiac echo probe, and you put it left parasternal area. This is the long axis, and this is the short axis, where the orientation marker is towards 3 o'clock, and you're putting the probe in the left high parasternal area. Now, once you do that, you will see main pulmonary artery coming down like that and dividing into the left and right. Commonly, this is described as a mustache sign. And you look for the turbulence in the main pulmonary artery. Now there is normally no turbulence, and when you put a pulse wave Doppler, you will see a clear tongue-shaped ejection waveform, and there is no diastolic turbulence in the main pulmonary artery. If there is a diastolic turbulence in main pulmonary artery, it is a surrogate marker that there is some blood coming into the main pulmonary artery during diastole, and that during diastole what comes is blood from PDA. So this blood diastolic turbulence is because of the PDA. So again showing diastolic turbulence in main pulmonary artery, left side laminar non-turbulent blood flow. There is no PDA. On the right side there is turbulent systolic and diastolic blood flow because of the presence of PDA. Now coming second aspect is, so when you how to decide pulmonary overcirculation, do the Doppler of left pulmonary artery, do the Doppler of main pulmonary artery. In both, look for flow during the diastole and turbulence. Now third one is look for the LA-AO ratio. Now this is something which was first described by Silveron way back in 1974. This is one of the first ratios. So it has got a historic importance to decide if the PDA is significant. Now when the shunting through PDA is significant, there is pulmonary overcirculation leading to dilatation of the left atrium. And that left atrium size is compared against a fixed size such as aortic root. So a long axis view is obtained. Parasternal long axis view is taken. So this is the probe. This is left side. So long axis view is taken like this. The orientation marker is facing 11 o'clock. And then you get a long axis view. And then you get, so this is the LA, mitral wall, LV, LV outflow tract. Aortic root is measured at the hinge points of the aortic wall. So this is the aortic root diameter. And LA is so again this is showing here the same thing, and the LAO ratio is done by putting M wave through the root of the aorta, and you see the diameter of the aorta and size of the LA. So this will come like this. So this is the beam LA ratio. LA is this distance. Generally LA distance does not change with systole or diastole of the heart, and LA size will change. LA size, so you take the maximum size of the LA, and aortic size is same. So this is the end systolic diameter, or so this is the maximum diameter of the LA which happens, and then compare LA upon AO ratio. So this ratio again, if it is more than 1.5, it is significant. More than 2 is more than definitely significant. But LAO ratio is affected by fluid administration, and taken alone is not a very sensitive or specific indicator. Now, assessment of systemic steel. Now, third important assessment is systemic steel assessment. So, as the pulmonary pressure reduces after birth, the PDA becomes hemodynamically significant. Now, the blood from systemic circulation is shunted across PDA and it goes into the pulmonary artery, and the pulmonary pulse wave Doppler. Basically, pulse wave Doppler is kept at the aorta distal to the opening of PDA. So, now this is the aorta. If you can imagine here, this is the aorta, and the pulse wave Doppler is just kept distal to the left subclavian, or if you are able to see aorta, if you are able to see the PDA, just keep it next to it into the aorta. And what you get is that a predominant anterograde flow during the aortic ejection, and then during the diastole there is a slow or low volume diastolic blood flow which is happening into the aorta. Now, if there is a significant PDA, this diastolic runoff, this diastolic blood flow, instead of remaining anterograde, it becomes retrograde and goes into the left pulmonary artery. So this diastole, the kind of the blood is going back into the pulmonary artery. So if there is no steel, so basically you have to again grade that amount of aortic steel. So if there is small PDA, there is no aortic steel. Moderate PDA, there is about 30% of anterograde flow is seen here. And if there is a large PDA, almost more than 30% of the anterograde flow will be seen in the reverse direction. So again, look for the flow in the SMA, mesenteric artery. Put the probe into the lower uh, subcostal view and orientation marker towards 12 o'clock. Try and interrogate the SMA, and you will be able to see absent flow in case of PDA, absent diastolic flow in case of PDA, and normal flow is seen like this on the left side. So summarizing, hemodynamically significant PDA parameters. So depending on the ductal constriction, good constriction, minimal constriction, no constriction. Size of the PDA 1.5, less than 1.5, 1.5 to 2.5, or more than 2.5 to 3. Duct velocity more than 2, 1.5 to 2, and less than 1.5. Large PDA will have a less velocity. And left pulmonary artery diastolic flow less than 30, 30 to 50, more than 50. Ductal flow for in the first 70 hours kind of is closed, is a closing pattern is a small PDA, and pulsatile pattern and growing pattern indicate medium or large size PDA. Ductal Vmax upon V minimum. In a small PDA, it is less than 2. In a medium or large PDA, it is more than 2. Then coming to the pulmonary overcirculation, LAO ratio less than 1.4 normal, 1.4 to 1.6 medium, and more than 1.6 is a large PDA. Then systemic hypoperfusion, distal aortic flow reversal is basically anterograde flow in a small PDA, 30% reversal in medium, and more than 30% in a large PDA. SMA Doppler, again same, anterograde flow, absent flows or reverse flow, and LV output. We have to remember, in a medium or large PDA, the LV output always is increases. It may be it is supranormal. So again, this completes my assessment of PDA. So again, summarizing my talk, the PDA can be a normal structure in the first 3 days. So how to look for PDA? Put the echo probe in the high left parasternal area, long axis. That means facing 11 o'clock, 12 o'clock. Tilt the probe little bit this side on the right side so that it will cut through the PDA. PDA is seen as a cephalad continuation of main pulmonary artery. Put the color Doppler, see the flow if it is patent or not, quantify the flow, put the Doppler whether it is a right to left or bidirectional or growing or pulsatile or a closing pattern. There are 5 patterns, and based on that also again assess the size and contour of the PDA, and again look for the signs of pulmonary overcirculation, and based on this you can take your decision whether you want to treat the PDA or not. So this actually